So this is a nice case of a 62-year-old gentleman who comes in with anterolateral ankle pain. And what we can see is that there is this anterior to the distal fibula. When we look on the sagittal imaging, moving towards the lateral ankle, we can see that there's cortical bone. So this is consistent with an os fibulaire. And when we look at whether or not it could be symptomatic, we see that there is a gap that's greater than 2 millimeters and there's some degenerative change. We see that the anterior talofibular ligament remains intact, and we can see this gap here. Now, what we're looking at in these regions here, so this is the calcaneofibular ligament, and we can see that that's in front of the peroneus longus and brevis, which brings us to this issue here. And when we look at this region, we have at the level of the ankle, we still have muscle. So let's go back to our T1s and try to work out what we have in terms of accessory muscles. So we have several different tendons, small subtendons here that are joining to brevis, and that's one of the variations that occurs with the cordis. So there's several variations. Some of these variations will go on to attach directly into the lateral aspect of the calcaneus. Some of them are going to attach to the peroneus brevis, and what we have is a split between the two halves of the brevis here. Now at this time we can see the superior peroneal retinaculum. Always want to see the fibrous ridge has some amount of elevated signal, but there's no pouch formation. The band is intact, and I see the two halves of the brevis. Notice there's a wavy split tear right there. So initially we see that the inframalleolar peroneus brevis tendinopathic, and then there are interstitial tears that extend to the insertion, and we can see this better on a coronal image. And when we look at the cross section there, we begin to see those two pieces of the brevis, and continuing on, we can see there are several split tears and an actual gap in the tendon to the base of the fifth metatarsal. And the longest, of course, going through the cuboid tunnel. There's some magic angle at this location, and it's intact. So what we can see at this point here, we can also see the calcaneofibular ligament wrapping around the base. And this is a setup for a problem for this patient because they have this os fibulaire that appears unstable. There's quite a bit of synovitis around it. We have the calcaneofibular ligament, which is around the peroneal tendons, and this entire complex is connected through where they attach on the inner aspect of the distal fibula. So we even have some bands of the posterior talofibular ligament coming in front of this region, and because of the degree of synovitis, there's a certain amount of rubbing that these tendons are doing against the ligaments and the bony structures, and that is leading to a greater degree of peroneus brevis pathology, or lateral hindfoot overloading forces is what I should say. So when we look at the other findings, yes, there's that osteochondral defect at the anterolateral distal tibia, which we can see that break in the cartilage and the fluid undermining that and the potential instability for this fragment here. So the findings on this examination, we see this peroneus brevis split tear beginning above the lateral malleolus with a higher grade split tear that extends to the insertion of at least or more than 50, just over 50% of the tendon thickness. And we have an intact superior peroneal retinaculum and an os fibulaire that's unstable with evidence of instability. On this initial examination also, let's take a look at the remaining. We have a comma-shaped navicular that's quite locked in there, that's going to restrict motion in this particular area. There's also an ossicle in here. Just other things here that are restricting the motion here at this subtalar, anteromedial subtalar joint. So in other areas like the peroneal regions, there may be greater movement or greater forces directed at it as the patient tries to heel strike and then toe off. The patient also has FHL tenosynovitis, which is typical along these patients, I feel, that have this posterior PTFL, thickening sprain and synovitis, chronic and high grade over time. This is a decompression of the synovitis in the joint through the FHL, and I usually give them some kind of measurement when it's extending through Henry's knot. Like in this here, I will tell them that tenosynovitis extends over that, just to hit it home that there's a lot of it. Okay, so moving on to our peroneal tubulization procedure is something that they do when the peroneus brevis tear is 50%. And they can create a wrapping around the peroneus longus and reinforce the tendon. Looking at where they do the procedure or where it was done here, how many sutures they put in, I'm not exactly sure, but I'm looking at the peroneus longus and the brevis here, and I get to this part here where I see that there's some bogginess to the tendon. Now, I always like to look at my images axially. So when I do that, I see, right away I see the superior peroneal retinaculum is lax and wavy, and there's even a pouch formed here and a lot of synovitis in the region. We see that the tubularized brevis has a thickened appearance, almost that there's more tendon here. So I see this part of the tendon has torn, and this is now circular around. This is a greater than 50% tendon tear. And one thing we can do here is look at this coronally. So let's try to see, this is the longest, this is the brevis, this is another piece of the brevis. And what we're seeing is the tendon then comes back to have those interstitial high-grade distal tears again, a little worse than it was before. Now when I look sagittally at this tendon, I might even be able to appreciate how thin this brevis looks now, or how irregular it looks. There's less fibers here. Probably some of it has retracted to this level. This is where I imagine the tenodesis, or the tubularization procedure of the brevis to the longus, is occurring. I'd like to get the surgical report to see if they did a distal repair at the time. If they have, there seems to be a re-tear, and there is a large amount of synovitis that is causing stress-related change all around, and of course there's a tear of the superior peroneal retinaculum. Looking at the region of the repair where they resected, there's this thickened. This will get thinner over time. Looking at their suture anchors, there's no backing out that I can see of these regions, and I see synovitis at this point. This can be post-surgical, or it can go on to be something that creates impingement. So that's, clinically we'll see how that is. And what I see mostly is that SPR issue. I'm looking at the rest of it, the FHL tenosynovitis, looking at the remaining parts of it. Let's see what they did with these osteochondral defect here. Looks like that's a little bit, I still see, it's kind of hard to tell post-surgically, but it doesn't look worse. It looks, that there's some defect, there's some edema, but I kind of see that they actually closed a bit of the gap here. And without it sort of joint distension, it can be hard, and I wouldn't go on to do that. I would check the surgical report, because I think they may have just even debrided the cartilage there. And thank you for presenting the case. We can talk about it again in school.